Good morning, everyone, once again. Dr. Sushma will be joining us. In the meanwhile, we'll go ahead with the lecture for the morning. Today's session is going to be delivered by Dr. Sanjeev Kumar. He is a senior resident at the Department of Onco-Anesthesia, Pain and Palliative Medicine at IRCH, AIMS, New Delhi. Dr. Sanjeev has 4 publications as PI and 8 publications as a co-PI in various national journals. He also has presented 2 papers at international palliative care conferences. His areas of interest revolve around artificial intelligence and machine learning in palliative care. And beyond this, with my limited interaction, Dr. Sanjeev Kumar is someone who's very prompt, very responsive, and quite helpful. So very warm welcome to you, Dr. Sanjeev, and over to you now.
Thank you, ma'am. Thank you so much. Is this screen visible, ma'am?
Yes, we can see your screen. Go ahead.
Yes, sure. Sure. Okay. So, good morning, everyone. Today's discussion is all about palliative care in humanitarian crisis. So, let us see how palliative care in humanitarian crisis started. What is the history of humanitarian crisis? So, this begins with Ashoka the Great. So, at 2060 before Christ, Ashoka was considered to be the most ruthless emperor of this planet. But what happens in 2060 BC is he launched a campaign against the kingdom of Kalinga. And after the carnage, destruction, and death that Ashoka has witnessed, he renounced war and he converted to Buddhism and devoting himself for peace. Since then, he started working for humanitarian aspects, and he developed multiple hospices built in Varanasi and multiple places in India. So these are the hospices built by Ashoka the Great. And that brings us to philosophy of life and death in Indian context. So as we all know, the soul cannot be cut by weapons, burned by fire, absorbed by air, nor can water wet the soil. As well as the other quote is where you can only rely on what you do and you cannot rely on what you get. So these are the 2 perspectives on which entire Indian philosophy of life and death is relying. So from here onwards, we will start our discussion on humanitarianism. So what has humanitarianism been described in modern eras is, humanitarianism is actually a response to the suffering and needs of others. And it is an action to protect the life, health, and also to ensure respect for human beings. Humanitarianism is motivated usually by charity and solidarity. And it provides support such as protection, food, water, shelter, sanitation, and education. Now let us see in modern era when humanitarianism was started in a structured way. So it starts from 1859 after Battle of Solferino in Italy, when Swiss businessman Henry Dunant started International Red Cross Committee. And the first meeting of International Red Cross Committee was held in Geneva, and its second meeting was held in 1864 at Geneva with First Geneva Convention. And after multiple conventions with additional protocols, a law was made that is called International Humanitarian Law. And this law is specifically made to protect civilians, health workers, aid workers, wounded people, sick people, shipwrecked soldiers, and prisoners of war. Now, let us see what are the fundamental principles of International Red Cross. So there are 7 fundamental principles that were developed in 1965. Out of these 7, 4 fundamental principles are very basic and core of the principles of International Red Cross. So the first principle is humanity, which actually means humanity is to prevent and alleviate human suffering. It also protects life and health, and it ensures respect for the human being, promoting mutual understanding, friendship, cooperation, and lasting peace among all people. Second fundamental principle is impartiality, which means there is no discrimination based on caste, creed, religion, gender, political opinions, and all. Third one is neutrality. Neutrality means taking no side in hostilities or engaging in controversies of a political, racial, religious, or any kind of ideological nature. And the fourth fundamental principle, which is the core of International Red Cross, is independence, which means maintaining autonomy to act with principles of humanity, impartiality, and neutrality. So after that, UNHCR has set a minimum standard for humanitarian charter. So the minimum standard for humanitarian charter was actually set by a project that is known as Sphere project. So what Sphere project suggests is that all human beings are born free and are having equal dignity and rights. That is freedom and equality. Second one is all people who are affected by disaster or any kind of conflict has a right to receive protection and assistance. So that is right to protection. And third one, everybody, including men, women, boys, girls, has their own rights as far as international humanitarian law is concerned. So that is considered to be everyone has their own rights. Now, after looking at the International Red Cross Committee and all this humanitarian laws, let us see what is humanitarian emergency and crisis. So in this slide, this is from Ukraine, and this is from very early days of Ukraine. It was suggested that approximately 2.5 million people took refuge in neighboring countries, with 1.5 thousand civilian casualties, and 1.9 million people were internally displaced inside the country, and 500,000 people reached with humanitarian assistance in Ukraine in a way or other. So this kind of crisis happens whenever there is a war or any kind of conflict like situation happens. Now, when we can call any conflict or any kind of emergency as a humanitarian emergency. So Oxford has given a test diagram in which we can look at the disaster and look whether international humanitarian aid is required or not. If it is not required, then it will be called as national or local emergency. If international humanitarian aid is required, then it is called as humanitarian emergency. Now check whether this humanitarian emergency is associated with any kind of political instability and armed conflict. If it is yes, then the situation is called complex humanitarian emergency. And if there is no political instability and armed conflict, it will be called as major emergency. Now let us see what are the types of instabilities and how it can be classified. So basically these instabilities are political, environmental, economic, and demographic instability. And it is classified in acute, chronic, urban, and protracted. And every classification has a certain kind of society to respond upon. So based on all these, there are 16 type of emergencies we can define. So these are all the 16 emergencies based on type of instability and its nature. Now, coming to a gross classification of humanitarian emergencies, that is, we can classify it in 4 groups. First one is conflict, post-displacement, natural disasters, epidemics, and disease outbreaks. Now, let us see how we are going to respond in cases of humanitarian emergency. So some points will be common in all kind of humanitarian emergency. So the first responder to any kind of humanitarian emergency is the government within its borders. Second one is emergency medical teams, which should be focusing on the treatment of acute injuries and illness, providing symptom relief, providing continuity of care to the patients who are already having existing illnesses, providing comfort and dignity to the patient who are not supposed to survive, and a dignified death. And this response should be either according to the international humanitarian law that is provided by International Red Cross, or humanitarian charter as per the Sphere project. So once we have seen how to respond to humanitarian emergencies, let us see what is palliative care and how palliative care is required in cases of humanitarian emergencies. So WHO defines palliative care as the prevention and relief of physical, psychological, social, and spiritual suffering of adults and pediatric patients, and psychological, social, and spiritual suffering of family members. It mitigates the pathogenic effect of poverty. It encourages active involvement by communities and community members. What is the need of palliative care? So the need of palliative care varies as per the situation, and the situation varies as per geopolitical location, economic situation, culture, type of emergency, and crisis. So studies has seen that low and middle income countries are more vulnerable to unnecessary suffering. So need of palliative care is more in low and middle income countries as compared to high income countries. Now, what are the principles of palliative care in humanitarian crisis? So the first principle is, the first goal of any medical field in any kind of humanitarian crisis is to save lives. So palliative care also supports saving lives. And the second goal is providing relief from the suffering. It is said that without palliative care, any kind of humanitarian response is actually medically deficient, and ethically it cannot be defined. But there are certain points where clarification is needed in the definitions, like palliative care considers dying as a normal process, but in cases of humanitarian emergencies, whether dying is considered to be a normal process or not. And palliative care never intends to hasten or delay the death. So these two definitions needs certain clarification as far as humanitarian crisis is concerned. It also, palliative care integrates life-saving treatments, and it should be started immediately for all patients. So there should be no delay and no one should be left behind. Now let us see how triage system works in cases of humanitarian emergencies. So this is a standard triage system which is used worldwide, and it classifies all the patients in 4 groups: red, yellow, green, and blue or black. So red is survival possible with immediate treatment. Yellow is patient is not in immediate danger of death, but in cases of normal times, this might be considered as an emergency. Green is patient will need medical care at some point after his critical condition is being treated. And fourth is survival is not possible even after providing the treatment. But there is a drawback in this categorization, and the drawback is this categorization does not make any mention of palliative care or symptom relief, and suggests that category 4 or the expectant patients require even less attention than those with minor health condition. So to mitigate this drawback, WHO has proposed a triage categorization in humanitarian emergency. So this is a recommended triage categorization proposed by WHO. And in this triage categorization, we can see blue is immediately next to red. So if any patient whose survival is not possible, given the care that is available, palliative care is required to provide comfort care and relief from his sufferings. Apart from that, in all stages, we can see palliative care should be integrated with life-sustaining treatments as much as possible. And in green category, symptom relief would be required. So as per proposed WHO trials categorization, expectant patient should be second to the category red patients. Now, coming to palliative care for people who are affected by various humanitarian emergencies and crises. So this classification and this recommendation is provided by World Health Organization, and it has been classified in 4 parts: physical suffering, psychological suffering, spiritual suffering, and so first one is physical suffering, where a person may sustain any kind of symptom due to acute injury and symptoms due to injury related complication. So in these kind of situation, what WHO recommends is, first one is to save lives, and second one is to relieve suffering. Then the next step is develop protocols with minimum standards, training of emergency medical teams, and providing equipments to them. Essential packages are very important, which include essential medicines, essential equipments, and essential kits. Apart from that, the training of EMT should have a minimum criteria at what level a person is trained to handle what kind of situation. This we will see in a later slide. So these are important, and in the next slide, it is continued in psychological suffering. So to mitigate psychological suffering, every emergency medical team staff should have a basic idea of providing psychological symptom relief. But if patient is having complex psychological problems, then expert psychological opinions should be required. Therefore, expert psychologists should also be there in the teams. Apart from that, certain kind of medications like SSRIs, benzodiazepines, and haloperidol antipsychotics, this should be included in the essential package for humanitarian crisis. Apart from that, a partnership with local community and spiritual leaders is very important. They can also help in mitigating the psychological crisis at the time of humanitarian emergencies. Next one is social suffering. So social suffering could be in form of loss of shelter, clothing, food, sanitation, loss of protection due to violence, etc. So this can be mitigated by support from the social workers and community health workers by providing access to shelter, clothing, appropriate climate, appropriate to climate and culture, providing food and sanitation. Protection from physical and psychological abuse should be provided. And apart from that, organizers support groups for patient and survivor who may wish to share their experience and challenges. This should also be maintained. And the last one is spiritual suffering, where spiritual counselors are supposed to come in picture so that they can curb the spiritual crisis at that time. Now, let us move on to the various type of humanitarian crises and what it has done in our past times. So first we'll start with conflict, and what can come in our mind is the ethnic genocide by Hitler and Nazis. So this was probably one of the worst conflicts we have ever reported and in the history. Now let us see what comes with a war. Why war is so devastating. So a certain pictures I have included in the slide just to show you what actually happens in the war. This image is from the war of Syria, and this quotation is also from war of Syria, where a 3-year-old wounded boy says that I'm going to tell God everything. This this quotation went viral across the internet, and unfortunately, the child didn't survive. So this is what a 3-year-old person thinks about war. Second one, a very famous quote by Bertrand Russell, that war does not determine who is right, it only determines who is left. Now let us see what happens in Russia-Ukraine war. So this is the data from first 162 days of Russia-Ukraine war. And this data suggests that approximately 5,500 civilians were killed in the first 162 days of war, with 8,500 injuries in Ukraine. And along with that, this war situation in Ukraine was considered to be more challenging than the situation of COVID-19. So this is how war can create challenges as far as humanitarian crisis is concerned. Now, let us see what is conflict and how conflict has changed over time. So war and violence has always been a major concern for humanitarian action and have catalyzed the humanitarian movements. But conflicts have evolved over the time, from interstate wars and intrastate wars to current times where newer technology has taken over and remote control airborne drones are being used for all these wars. As a result of all these new type of warfare machineries, humanitarian response must prepare nowadays for the following 4 conditions. And these 4 conditions are: we should clearly have an idea that locus of war is no longer coincide with state borders. Instead of states and their militaries being the main agents, non-state actors are also playing an increased role. And economies of war are no longer financed principally by government tax revenues, but increasingly from illicit activities, aid and plunder. And instead of uninformed combatants being the main victims, civilians are increasingly paying the lion's share of the cost. So this is about conflict. Now let us see the second humanitarian crisis, that is called forced displacement. So forced displacement is any kind of group of people who are displaced from their natural habitat. And this could happen either because of conflict, because of natural disaster, environmental degradation, poverty, or political oppression. UNHCR report of 2015 suggests that 65.3 million global displacements occurred in 2015, with 21.3 million refugees and 40.8 million internally displaced population. Now, there was a very common saying that those who are in refuge are facing much severe health and social issues, while studies suggest that internally displaced populations are more affected as compared to refugees. And the death rate among internally displaced population is almost twice as compared to the refugee population. So UNHCR report in 2022 suggests that 103 million people were forcibly displaced worldwide. Out of that, 53.2 million people were internally displaced and 32.5 million people were refugees. 4.9 million people seeked asylum in any country, and 5.3 million people are the people in need of international protection. Now, out of these 103 million displacements, 72% of the displacements originate from 5 nations. And these nations are Syria, Venezuela, Ukraine, Afghanistan, and South Sudan. 36% of all these displacements were hosted by 5 countries, that is Turkey, Colombia, Germany, Pakistan, and Uganda. So out of 103 million displacements, 36.5 million were children. 1.5 million children were born as refugees. 204,500 refugees were either returned to their hometowns or home countries, or they were resettled somewhere else. And 74% of all these refugees were hosted by either low income countries or middle income countries. So these data are from UNHCR. Now let us see how palliative care helps in cases of conflicts. So the first step is to save life. Second step is to provide palliative care in form of providing physical symptoms, providing psychological symptoms, providing spiritual symptom relief, and if patient dies, providing grief and bereavement support to the survivors. And the second concept is do not hasten death for the expectant or blue category people. Now, next humanitarian crisis is natural disaster. So natural disaster can be classified in two groups. Either it could be geophysical hazards or it could be meteorological hazards. Geophysical hazards are earthquakes, tsunamis, volcanic eruptions, and meteorological hazards are flood, storm, hurricane, and heat waves. Natural hazards have been increased by human activity and environmental degradation, and the consequences depends on the vulnerability of population. So risk of natural disaster on population can be calculated as a product of hazard and vulnerability. Now, let us see a few natural hazards which we as a nation faced in last 20 to 30 years. The first natural hazard was Gujarat earthquake in the month of January 2001. And the epicenter was near Bhuj, and approximately 15 to 20,000 people lost their lives as far as the reports are concerned. And approximately 30 to 40,000 people sustained injuries. Now, how humanitarian aid agencies has responded to this crisis? Various humanitarian agencies across the globe supported our government and supported the people of Gujarat in various form, either in monetary relief, either in form of monetary relief or in form of relief materials. Relief materials were either in form of objects or in form of human resources. Human resources included emergency medical teams and other workers who were sent to the affected place to help the people. And as far as nations, so these are the nations who have supported various in various forms, and either in monetary terms or in terms of objects and manpower. So why this is important is because we'll see in the end, humanitarian response is actually an act of solidarity. And this actually shows that whenever a crisis happens, no one is supposed to be left alone. So everyone should stand in support of the person or the country who is in crisis. The second crisis was Indian Ocean tsunami of 2004. And the impact of Indian Ocean tsunami of 2004 was, it almost killed 2.5 lakh people across the Asian and Southeast Asian nations, with approximately 1.25 lakh people sustaining injuries, and 17 lakh 40,000 people were displaced because of the tsunami. Highest displacement, deaths, and injuries were in Indonesia, and India being the third most affected nation of 2004 tsunami. Now let us see how international aids received by various countries in 2004 tsunami. So the maximum aid was received by Indonesia, followed by Sri Lanka, India, Maldives, Thailand, Somalia, Burma, Seychelles, and Malaysia. And all these aids were received from various countries and various organizations. Out of that, private organization and private donations were the maximum. This is the list of top 10 largest donating organizations. Now, how all these donations were utilized in the tsunami? So most of the money was utilized either on food or on shelter and non-food items, or on the health and safety, coordination and support services. So these are the four areas where most of the money was utilized: food, shelter, health, and support services. Apart from that, there are certain areas like protection of human rights, agriculture, education, water, and sanitation. So these are also very important, but most of the money was utilized on providing basic support to sustain living activities. Now coming to palliative care in natural disasters, how palliative care can be provided in cases of natural disaster. So what kind of injury is most common in earthquake? And that is crush injury. Now, what are the complications of crush injury? It can cause immediate death. It can cause local or systemic infection. It can cause acute renal failure, and it can also cause cardiac failure. Now, in 2010, Haiti has an earthquake of magnitude 7, and it was found that post-quake, people were started having problems of acute renal failure. And in Haiti, there was a very limited facility of providing hemodialysis. So post-quake times, patients died because of renal failure, and that was because there was no availability of adequate hemodialysis facilities. How tsunami impacts? Tsunami causes loss of infrastructure and health problems like trauma, injury, aspiration, pneumonia, tetanus, and gangrene. In 2004 tsunami, Indonesia has reported 106 cases of tetanus, and the case fatality rate was quite high with 18.9%. Respiratory and soft tissue infections that happened during tsunami and after tsunami were actually because of very rare pathogens and drug resistant organisms. So it was very difficult to treat. So post tsunami death tolls were high because of all these infectious diseases. Now, role of palliative care. So a need of palliative care is for pre-existing illnesses. So in any kind of natural disaster, the most common sufferers were those who have been directly involved in the event. The second one is those who are already having a pre-existing illnesses, who are having chronic illnesses and are on regular hospital care. So their hospital visits are lost, their hospital care is discontinued. Second one is patients who are disabled. So they require palliative care for their symptom management. Palliative care is also required for the ones who have lost access to healthcare. And it is very important to provide psychological support, because people who have witnessed death and who have witnessed so much of disasters surrounding them may land up in severe psychological distress. This we will see how severe this can be in coming slides. Now coming to the next humanitarian crisis, that is epidemic or disease outbreaks. So this image is taken from USA Today, and this image is from India, which shows a crematorium ground where all these COVID patients are being done their last rites. Now, what happens? What is epidemic and a disease outbreak? So any kind of public health emergency that requires international concern is called as epidemic. And this definition was given by UNIHR in 2005. So what is public health emergency? Public health emergency is any kind of extraordinary or unexpected event, which is either a public health risk to the other state or country, or it requires a coordinated international response. For example, recently we have seen two major epidemics and possibly one pandemic as well. The first one is Ebola outbreak between 2014 to 2016, having a very high case fatality rate among pregnant women and children. And the CFR was 70% with a toll of 11,000 people. The next one is global pandemic, that is COVID-19, having 766 million cases and 69 million deaths worldwide, with 45 million cases in India and 5.3 lakh deaths in India, as far as the reports are concerned. And this is the data up to May 17, 2023. Now, let us see how the community and society takes the lead in providing support while any kind of humanitarian crisis has arisen. So this image is taken from USA Today, and it was taken on April 24, 2021, where a patient in his car suffering COVID-19 and requiring oxygen support and awaiting hospitalization was provided oxygen support by a Gurudwara. So this image shows how our religious places and places of worship are supporting people when any kind of crisis appears. The second one is how the society acts in cases of humanitarian crisis. So this place which looks like a hospital is actually not a hospital but a banquet hall. And this image was taken on April 28, 2021 with courtesy of USA Today. And this banquet hall was converted to a temporary hospital with all the required facilities so that all these COVID patients can get admitted and have whatever is required. The third one is human-to-human interaction. This image was taken on 25th April 2021, courtesy USA Today. And it is from Jammu and Kashmir, where a patient is not there, and patient is buried. And then this immediate relative of the patient is being consoled by either by the healthcare staff or by the other relatives of this patient. And the third one is, the last one is, this image shows how non-governmental organizations, how municipal corporations, and how all the healthcare staff and infrastructure was trying to help all these patients till they survive and even after their death. So this image was taken from a crematorium in Delhi on Saturday, April 24, 2021 with courtesy of USA Today. And this shows that these people who are helping in proper and adequate burial of the dead bodies were exhausted and sitting on back of the ambulance. Now let us see palliative care, how we can provide palliative care in cases of epidemics or pandemics. So WHO has recommended responses in cases of epidemics and pandemics. So these responses are again in 4 categories. The first one is physical suffering. So either the physical suffering could be directly because of the disease or because of the treatment. So very important is to place the policies. And the second one is to train and provide equipment to the emergency medical team. Protocols should be developed to manage all type of diseases. Essential package is very important. We will go through these essential packages in coming slides. And a basic type of palliative care training is required for all emergency medical teams. So this we will also see in coming slides. Now, providing psychological support. So again, every emergency medical team staff member should have a basic idea of providing psychological support. They should have a certain kind of drugs in their essential package. They should have access to local spiritual leaders. They should have access to trained psychological staff. And in cases of complex psychological problems, they can contact the trained psychological support teams. So these are the recommendations by WHO for psychological suffering. Social sufferings occur in form of poverty, stigma, isolation, vulnerability. So this can be mitigated by providing shelter, clothing appropriate to climate, food, sanitation, protection from physical or psychological abuse. Monetary supports can be provided in cases of extreme poverty. Educational facilities can be provided. Again, psychological support is very important. And reintegration programs for survivors are very important. So these are the recommendations for social sufferings, and the last point is spiritual suffering, where a person has a sense of loss of meaning in life and loss of faith towards God or anger towards the God. So these situations can be handled by seeking partnership with local spiritual counselors who are willing to visit the family, and for the patient who are in isolation, provide a spiritual counselor and infection control training and equipment necessary for their safety. Now let us see what are the types and prevalence of suffering in humanitarian emergencies and crises. So again, WHO has classified all these type of sufferings in 4 categories. The first one is pandemic, Ebola epidemic, earthquake, genocide, and influenza. So what we can see is there are certain type of symptoms. All these crosses are actually positives. So do not get confused. These crosses means the symptom is present. So do not get confused with that. So pain is present in this is physical pain. This pain is physical pain is present in most of the cases, whether it is Ebola pandemic, earthquake, genocide. Dyspnea is present in most of the cases. Apart from that, if we see what is present most is acute stress reactions. So psychological suffering is very common in any kind of humanitarian crisis, post-trauma stress disorder, other anxiety disorders, depressive symptoms are present, and complicated grief is one of the most common and difficult symptoms to look after. So these are the various symptoms that happens in cases of humanitarian crises. Now let us see what type of pain happens at what location. So if you see in Ebola, mostly headaches. In lacerations, it can happen at the site of injury. Fracture, in fracture, it also can happen at site of injury. Internal head injuries can cause any kind of pain. Internal organ injury can cause chest pain or abdominal pain. Psychological stress is again a very important type of pain that can produce any kind of pain, whether headache, neck pain, chest pain, abdominal. It can present in somatic or it can remain psychological as well. Let us see how difficult psychological pain is and how severe psychological pain is and what consequences it could cause upon. So psychological pain is something very difficult to assess, and it is very difficult to looked after as well. Now I'll show you one image which you all might have seen somewhere here and there on internet. So this image was taken by Kevin Carter, and this image was awarded 1994 Pulitzer Award for the best photograph. This image was taken in 1993 by Kevin Carter. He was a photojournalist from South Africa, and he was working in South Sudan while Sudan was facing famine. So at the time of famine, this little boy, this is actually boy, but on internet it is said that it is a girl. So this boy, this approximately 3-4-year-old boy was hungry and actually limping to reach to World Health or United Nations food aid teams, and the food aid teams was approximately 1 mile away from this place. While this boy was limping, a vulture was awaiting there, and the vulture was awaiting the boy to die so that he can have a feast. So Kevin Carter took this image and went off. When in 1994, this image was awarded Nobel Prize, Kevin Carter committed suicide 3-4 months later. And in his suicide note, he has written that he has witnessed so much of starvation and so much of agony and suffering he could not help upon. And that makes him took this drastic step. So this is how psychological pain can reflect upon. This is how severe psychological pain can be. And Kevin Carter was just 33-year-old at time of his death. Now, as we have already seen, what are the essential packages? So World Health Organization has suggested an essential package in form of EP-HUM. And this EP-HUM is known as Essential Package for Humanitarian Crisis. It includes intervention, medicines, equipment, human resource, and social support. So this is how the EP-HUM contents are. Now let us see what is there in the EP-HUM. So it contains various medications for management of pain, for management of infection, for management of psychological well-being. It includes equipments, basic equipment like nasogastric tube, urinary catheters, opioid lock boxes, lights, and it also requires doctors with basic palliative care training and nurses and community health workers with basic palliative care training. So these are the medicines. With morphine is having a very important role in cases of humanitarian crisis. We'll see in a coming slide. And for social and for providing social support, social workers and community health workers are required. For prevention of relief from psychological support, all these antidepressants and antipsychotic drugs are included in the essential package, along with doctors and nurses with basic palliative care training. And to provide relief from spiritual distress, spiritual counselors are considered as a part of essential package for humanitarian crisis. Now, morphine and other opioids are very important as far as EP-HUM is concerned, because morphine is very fast acting and it is available in oral and injectable form, and it can be used in any kind of pain, acute from chronic, acute to chronic, and the severity should be moderate to severe pain. It can also be used in patients who are having severe pain and they are in terminal stages. And morphine can also be used in cases of refractory dyspnea. Now, what are the barriers in providing opioids? So, United Nations has suggested that there are certain barriers like lack of prescriber training, fear of production, addiction and dependence on opioid analgesics, financial constraints, fear of diversion, clinician fear of being prosecuted for prescribing opioids. So these are the basic barriers in providing opioids. Now, as we have already seen, what is the training required to have palliative care experience as far as human resource is concerned? So WHO has given a clear-cut classification. Specialists should have a training of 1 to 3 years, and this is for doctors and nurses. Intermediate training is of 2 to 6 weeks, and this can also be for doctors, clinical officers, assistant doctors, nurses, etc. Basic training is just of 35 to 70 hours, and this can be done by doctors, clinical officers, assistant doctors, anesthetists, nurse practitioner, nurses. And rudimentary training is for 3 to 8 hours for community health workers. So these are the essential training sessions that can be attended by various people who are involved in management of humanitarian crisis. Now, social support system for patients and family caregivers, it is very important to include basic food packages, housing facilities, gas, transportation, clothes and sleeping bag, self-care equipment, and providing support for appropriate burial and disposal of bodies. Now, implementing palliative care in humanitarian emergency and crisis. What are the practical considerations? So the first two steps is prevention and mitigation of the situation. And if any kind of humanitarian crisis arises, prepare for that. Let us handle the disaster, respond to the disaster, and recovery after the disaster. And after recovery, there is an important aspect that is called reconstruction. So these are the various United Nations organizations that are involved in management of any kind of humanitarian emergency. So these are the key humanitarian agencies, and in cases of disaster, the government of the affected state actually has the primary responsibility for coordination and management of all the response operation. But when the scale of any emergency exceeds the capacity of a state to respond, it may require support from international organizations. So these are the international organizations available to support in cases of various humanitarian emergencies. With this, I come to a conclusion, and the conclusion is any kind of humanitarian emergency can be mitigated by solidarity. And in Indian philosophy, solidarity is considered as this statement, I am nija paroveti garna cha laguchitsam, udar charitanam tu vasudhaiva kutumbakam. This means there is no concept of mine and not mine. Those who think that this is mine, that is not mine, is actually a classification provided by people with narrow-minded. For the noble-minded people, the entire world is actually a family. So this quote is from Hitopadesha. Thank you.
Beautiful, Sanjeev. Beautiful. If this would have been a physical class, we would have given you standing ovation. This was such a beautifully prepared class, Sanjeev. And the best part which I want to share with everyone, first of all, I'm sorry I joined late, 5 minutes late, because I was in another meeting. This class which Sanjeev has prepared, it is just 3 weeks back I told him that you have to prepare this class, because the previous speaker whom we have given this class, she said that she is unable to prepare this class. And see how beautifully Sanjeev has prepared this class. And I just want to share, because we have 7 minutes, that people keep saying that NCI Jhajjar COVID services were the excellent in Delhi. I don't know about the India. But most of the time, which I keep feeling that why people are saying, and still people discuss this in the ministry or in every forum, most of the time which I feel that why they were saying this is mainly because the palliative medicine residents of our department, they were involved thoroughly in every aspect of care of these patients. So how Miss, like I can't practical experience of other casualties, but COVID casualties I can share some experiences. Which first paper which Sanjeev only published, that is stigma amongst the patient, those who were only suffering with mild COVID. So imagine Sanjeev has given the various categories: green, blue, green, red, and every. So yellow. So in even the mild people, they were suffering a lot, and how palliative medicine residents, they were helping them, and that Sanjeev can share. And then I would like to share. I would like to ask Karanveer, who is there, who is again one of my MD student, and I have that time we were distributing thesis, and I was working over there. So I asked him to take care of the patient, those who were suffering with mucormycosis. So mucormycosis, the patients came and we forgot completely. But have you ever thought that the patient, those who operated, those died? I think that they were better, because those people, those who were operated and disfigured completely forever for life to live, how they are feeling, because he is still finishing his last, he has shown his data and analysis, and I was shocked to see the data that how people are still suffering the mucormycosis. We have completely forgotten, we have started our routine, but this is a thing to highlight, that if we how people are still suffering in after so many days. So I would like to share, I would like to ask first Karanveer, that Karanveer, what is the experience of patients after 1 year of mucormycosis? Because this was his thesis topic, that what are they feeling, physical, social, spiritual, and social problems in first when they were in the admitted, then 3 months, and then 6 months. So Karanveer, can you share this briefly? And then Sanjeev will share about stigma.
Yes, ma'am.
A very good morning, ma'am. Thank you for giving this beautiful lecture and moderating it. It was a very informative class. And as for the mucormycosis data, ma'am, in our institute, we did a data for the patients who are admitted with purely with COVID-associated mucormycosis, ma'am. And we have found a lot of important points, which include that our patients had a predominant of sinonasal and rhino-orbital localized mucormycosis, and it was the predominant form of mucormycosis which was seen, and a total of 53 patients were surveyed during the whole period, ma'am, and which we kept on follow-up for 6 months and 1 year. And the patients who had cerebral involvement at the baseline, 6 patients included those group, and the cerebral patients, none of them survived because it was such a fatal disease. And presented with sinonasal and the localized disease, they had headache, severe headache, facial pain, redness of the eyes, protrusion of the eyes, periorbital swelling, nasal discharge. And in the advanced stage, we could see that patients presented with limb weaknesses, facial palsy, altered sensorium. So if we recognize these symptoms promptly at the early stage, many of them could have been saved and could have been salvaged. In our study, there was a 15% mortality rate at 1 year follow-up. So 15% of the 53 patients had expired. Even during the treatment part, when the patients were admitted for a long time, underwent repeated surgeries, they underwent repeated debridements of the necrotic tissue, of the fungal tissue, as well as they were giving a posaconazole along with the amphotericin B. So amphotericin B was a very dangerous drug and very beneficial drug because nothing else would work. But when it worked, it caused so much of diarrhea, it caused so much of infusion reactions during the period that almost the whole ward was affected when the deoxycholate amphotericin B used to come, because in between the liposomal supply was off due to high demand and due to supply demand issues. So other than that, these were the physical issues which the patient was facing. We also assessed the depression and anxiety using the PHQ-9 and the GAD-7 questionnaire and the WHO QOL-BREF questionnaire, which was for the overall quality of life. And on the follow-up, we have seen that as the patients were treated correctly and managed correctly, we have seen that they have improved in their quality of life and anxiety and depression scores, but they still have significant issues regarding their appearance, which was particularly for those who underwent orbital exenterations. The patients, some of them have lost their jobs, some of them have significant appearance issues, they have increased social isolation, they're not going outside, interacting with the people. So we came to know that apart from just the physical manifestation, there are so much other things which are playing into role for these patients, and it can have a huge impact if managed correctly. And integrating palliative medicine in these group of patients does surely have a great role so that they can be integrated back into the society with regular counselings and helping them. And that's
Thank
all
you,
I would
Karanveer.
like to
I
briefly
think,
say.
thank you, Karanveer. Quickly, in 1 minute, Sanjeev, can you share your experience of having stigma? It was such a big problem
Yes,
amongst early stage. Just 1 minute, huh?
Yes,
1
ma'am.
minute.
So the patient who were reported to us, they have huge huge burden of stigma, and the stigma was varying at various levels. One was at patient perceiving stigma, the other was at family perceiving stigma. Patient was admitted in a hospital and family was suffering stigma 500 kilometers away from the hospital just because the patient is having an infection, that is COVID-19. So this kind of situation happened, and this put all of our patients to a level of stress that they stopped disclosing their medical health conditions to their family members and to their friends and societies, because this was creating a lot of. What we did was we started talking to the patient on telephonic basis because it was difficult to be in touch personally. And after we have seen after 2 to 3 talks, these patients started responding positively and they started talking to their family members. One patient said us that people have stopped walking in front of their doors just because their family has a patient who is admitted to the hospital. So this kind of situation, a mother was there who was separated from her baby, and it was a newborn baby, just a delivered baby, and she could not see her baby just because she was COVID positive, and family were like putting a pressure on the patient that it is because of curse of the patient that she has developed this disease, and she might not be able to see the baby, but she got cured. She got reinstituted in the society, and she was able to hold her baby. So if we
Thank you,
consider,
Sanjeev. Thank you, Sanjeev. So this is the way, Sanjeev, Karanvi, these are the two residents, but there were at least 25 palliative medicine residents, those who were looking after COVID services. This was the recent humanitarian crisis, and we have seen, we have witnessed, we have applauded with our services because I was chairing this task force. So everything, but I can say that it is mainly because of the palliative medicine residents with other help, definitely with other people, those who were looking after with good clinical services with all 35 departments. I think they did a great job. So this is the way palliative medicine can help. This is just an example. And Sanjeev, again, I want to say, there are so many compliments. Archana, I would request that all the compliments please pass on to Sanjeev.
Sure, ma'am.
I want to say the presidents like you are basically treasure for future of palliative medicine in India. So this is the way palliative medicine, and because you have not only accepted my request within no time, but you have read a lot. And Dr. Nandini has given a very good compliment to you that you have read a lot and you have surveyed various data, various situations, and you have brought everything in 1 hour. This is a topic where everybody wanted to have a lot of comments and compliments personally. And there are some questions also. So Archana, what I will request that please pass on these questions to Sanjeev or me. We will try to answer these questions in the group. So I'm sorry, we will not be able to take any questions right now because now the time is over and everybody will have to go for job, their work. But again, I want to say that this was a fantastic class and this was an important class, and maybe we will have this kind of class in future with the small topics in different, because there are so many aspects. People are asking whether there are training available, whether anything, whether their courses available. So we will discuss all these things in groups. And thank you, Sanjeev and Karanveer.
thank you.
There are many residents. Abhinav is also doing thesis on COVID patients. I can't see Abhinav in the group, so I have not asked his comments. But you did a fantastic job, and Sanjeev, this was a fantastic class. I'm so proud of you. I'm really proud of you.
Thank you so much.
Thank you, Archana and Nisha. They were kept calling me, but I was unable to take their class also in the starting. Thanks a lot. Their phone also.
Thank you so much.
Thank you.
Thank you so much.